Hello, welcome to a new session. Today, we are going to be talking a little bit essentials of biomedical computing, and we are going to introduce concepts of databases and networking. But before, let's review our learning objectives, and we want to describe health information systems, and we discuss the role of database management system and networking in healthcare delivery, and we are going to be describing various database management systems. Let's let's start with the concept of health information systems. And to approach this, we need to remember what we have been talking about, the information cascade. How things that we measure or observe, we call the data. Anything that we can measure with an instrument with our senses or we can observe is going to be called data. That data, when we provide meaning, is becoming information. That information, when we provide interpretation or you provide context, and is going to be creating knowledge. That knowledge is going to help us to interpret new information and create new knowledge. And then we can use that knowledge for making decisions, and some authors call this wisdom. The most important thing here is that you see the only thing that really exists outside of our brains is data. Everything else is human dependent. And then we need to be aware of that. Even though we are going to be talking about health information systems and information, maybe they should be called health data systems because we are going to be computing in the data level. But that's a trade-off that we can have, and that's really important because at the end, the information systems, what they're trying to do is to maintain this cascade in a consistent way, in such a way that people with a similar context, similar knowledge, they can obtain similar information or at least being approached. That said, when we talk about the data processes and the information systems that are going to help us to capture, to store, storage, to curate, to transport, to search, to retrieve, transform, analyze, visualize, and update the data. Then any system that is going to help us to do any of these elements with data is what we're going to be calling information systems. But what is a health information system? Then there are several definitions. We can say that there are standardized tools that we can use for assess, monitoring, evaluating, and processing health-related data into valuable information, which supports evidence-based healthcare management. As you see, it's a system that is managing that data in order that humans, we can use that in a consistent way with the ultimate goal of making decisions and applying knowledge in the real world. The NCHS defined as systems that captures and report aggregated health statistic information. That's a reduced perspective of what a health information system is, but it's a valid approach. And you see that we use information interchangeable, but we really are meaning that we are dealing with data because it's really difficult to represent the thing that I'm thinking or my interpretation. What we can really represent and store is the observation. And the WHO, the World Health Organization, says that health information systems are integrated efforts to collect, process, report, and use health information and knowledge, influencing policy making, program actions, and research. And further states that they are essential to effective functioning in health systems worldwide. You see that these are different levels, but at the end, is any system that is helping us process data in those levels to make information, to make knowledge, to make decisions is going to be in that domain. And the characteristics of the data is data that is health related. Now, if we want to look into the history, we can say that information systems were originated in the early 1800s when, for example, John Snow were creating the nation or the birth of the geographic information system. He already have these really nice maps that they were representing things that were happening in London, and that's the origin of those information systems that uses geographic representation for displaying epidemiological data. In the mid 1800s, then we started having surveillance systems based on viral statistics. And that's what has evolved to the International Classification of Diseases, or the ICD-11, that is the current version, or the ICD-10, that is one that is implemented in the United States. In the early 1900s, then there were developed some death registries, and that's an evolution of the surveillance and viral statistics to be able to say, hey, we need to classify better and understand why the people is dying and what are the causes of mortality and morbidity. And it included America, Europe, and Asia, and that was expanding. And now we have global registries. And when we faced COVID, if you remember, we were having this almost real-time surveillance of what was going on with not only the morbidity, that is what happened with William Farr, but what's happening with mortality. And we were really using those information systems in real time. In the 20th century, then we started to develop population-based surveys. Then we have the National health survey that is run with a periodical time, and I'm going to provide you some link and you can go and look into that data set. That is really interesting. And in the 21st century, then electronic health records were really established, and clinical decision support systems are blooming, and we have a lot of new things. And now we are facing artificial intelligence, and how artificial intelligence is going to modify the relationship that we have with the data, the relationship that we have with the decisions, is something that is still to be written. And if we think about technology adoption in the United States is reflected by this graph. And we can see that at the beginning, any technology took some time to be adopted. Even some technologies are being not used anymore, like the landline, but you can see that since the mid 90s and the 2000s, we have spikes in implementation of technology. Then the computer, the cell phone, internet, smart devices, those has a spike, and those are opportunities to create new ways of collecting data, new ways of transporting data, new ways of utilizing data. And also, it comes with the addition that we are creating a lot of more data. Then this has created an ecosystem of technologies. And we can see that, for example, if we are centered in the hospital, that is the traditional way of seeing healthcare, we have the traditional hospital information system. The hospital information system, or HIS, or the ERP, that is in the enterprise a management system that is going to be in charge of managing all the flow of the production. Then are going to be those first elements that we implemented in healthcare to actually be efficient and optimize services. But we have a lot of acronyms that we are going to be exploring, like PHR, personal health record, EHR, electronic health record, CPOE, computerized physician order entry, LIS, the lab information system, the PIS is the pathological information system, the RIS is the radiological information system, the PACS is the picture archiving and communication system. All these are evolutions for the need of managing that data and presenting to the decision makers. And now we are dreaming we having this universal health record that we are able to bring data from different sources and be able to integrate them around the patient. And if you're not familiar, then the radiological information system, the PACS, usually is this computerized system where we can take the images, transport the images, analyze them. We can do 3D reconstructions. We can do really interesting things with the images. Or the pathological information system, similarly, it takes advantage of artificial intelligence to identify patterns, to identify problematic areas, and make recommendations and try to match some diagnosis or look for differential diagnosis sometimes. The laboratory information system is not just collecting the data from the lab results, but we can contrast the results against goals. We can contrast the results from data from an electronic health record and see if a medication is effective or ineffective. And this is just from the point of view of direct healthcare and in the hospital. something important is when we implemented the electronic health records, basically sometimes what happened is we shifted from big cabinets with paper to big cabinets with cables. What happened? There are so many reasons, but the incentives to implement electronic health records has not been really in the history to improve patient outcomes or to improve healthcare delivery. They have been to optimize the services and be able to guarantee the revenue in the institutions. That's something that we hope to correct and to improve, but that's one of those realities when we are talking about the history of the electronic health record and what are the motivations and the incentives to implement that. Now, I want to think a little bit how the technology, the health information systems have influenced the way that we think about health. And this is a concept that I had been introduced a couple of years ago, that is the concept of health 5.0. And recently I was just talking about all the way to the 4.0. And if you see, when we look into the evolution of the way that we think about health, and we went from the reactive medicine to prevention, promotion, and now we are talking about participatory and predictive care. Because data has allowed us to gain knowledge, and then when we were reactive, we were just learning about, okay, I do this work, okay, I keep doing the things that work. But when we start doing prevention, we identify, hey, there are some factors that I can modify because I have learned from the history that if I modify that, then I'm going to have less effect. Promotion is now avoiding risk activities that are going to put me on danger or facilitate the occurrence of a disease. And the participatory predictive is now that I know even a lot of data about you even before you are born, because we can have genetic screening or things like that. We can say, okay, then in the future you have a risk of developing certain disease, how we are going to manage that. And people is empowered with data today, and now they can participate in the healthcare, and they have a decision making in their role. The care systems also, they have been modified and facilitated because the technology, originally we have the home with the outpatient consultation, we have the hospital, but when we start evolving with technologies, we were able to reach out to the community, we were able to reach out to the pre-hospital environment. We were talking about distributed environments because the healthcare is fluid, and now we have a scenario that is ubiquitous. We can deliver health in any place in the world. We have telemedicine, we have telehealth, because technology communications allows us. And health records, I already tell a little bit about that. And we have paper, we moved into electronic health record. Then we have been talking about those personal health records. When you have your patient portal and you can have your results in your own phone, or when you can have your Fitbit data, when you can have your Apple Watch data that are giving you some information, the monitoring of the glucose, things like that. Those are personal health records. What happened is they are all non-connected and distributed in such way that we are still dreaming of this concept of the universal health record that I previously mentioned. And communication is also has been modified by technology, because initially it was direct. We used to go to the doctor, to the nurse, and we talk directly. Now we have and then we have the email, and if you think about now, the results comes through email. It says, hey, there is an email here and your results are ready. Maybe you need to go to a portal or you need to go to the app to be able to retrieve that. But email is a really common communication strategy in healthcare. But also we have instant messaging. I don't know if you remember when we have these chatbots, when we had COVID, that we can talk with these agents, or we can just text to make appointments, or we can just receive a quick update. Hey, your results are ready, and we receive that in the phone. And in the 4.0 series mediated is when we have really technology that is helping us to direct that communication. And sometimes it's frustrating because sometimes we want to have that direct communication. We call to a call center, or we are chatting with an agent, and it's almost impossible sometimes to get a human because the machine is limited in the process. And the relationships, and this is more in the commercial direction, it was direct. Then that contract was within the provider and the patient. Then we started to see the insurance companies, and it's a triangulation. That's when we have the HIPAA regulations in order how the data was going to be exchanged and how the data which should not be used against the individuals. But now we see that we have service networks. The insurance are integrated vertically, they are absorbing health systems, and now we have really complex network of services. And what we are seeing is the medical systems, big names attached to a series of hospitals or a series of services that are providing that. And now you are not related exclusively with the provider, but your relationship is with the whole network or the whole medical system that you are involved in. And diagnosis and treatment also has evolved, because at the beginning the knowledge was centered in the provider. But then we have the clinical practice guidelines. It allows a little bit of socialization and a delegation of care to other participants in the healthcare. And computers were strong enough to provide clinical decision support systems, and then computers were assisting humans in making decisions, making prescriptions, looking for errors, looking for inconsistencies, things like that. And now we have clinical agents that basically you can talk with a computer that is going to be recording your interaction, is going to be asking the questions that a physician could be asking, and is going to help make that diagnosis and that treatment. And that's something and that is real for now. What is coming is that Health 5.0. And what we are going to be seeing in the future is more self-care, because we are having a lot of data that we can obtain ourselves, and we have magical machines that are called cell phones, smartphones, that can process that data and provide us a feedback. The hair is going to be extended reality. Now it's not just in the physical plan. We are going to have simulations. We are going to have augmented reality. We are going to have virtual reality to support the care, and there are multiple examples of those already. But the most important thing is the health. We are going to have so much data from individuals that we are able to create digital twins, basically create a detailed clone of yourself that is going to include your genetic data, all what we know in the clinical, all that we know about your exercise, your diet, your sleep habits, your movement habits, your daily activities. And we can create simulations there to understand what is going to be the best alternative of care for you. The communication is going to be continuous, assisted by agents. We are going to see definitely global networks, and healthcare is going to try to go to that dream of personalization that with the help of technology and the help of humans, we are going to be able to tackle your specific needs. Then in that regards, if we look into the sources of data, we see that we can have sources from the individual level, we can have sources from the health facility level, we can have sources from the population level, or from public health surveillance, or even from registries. And when we are talking about health information system, there are different levels from where we can grab the data. The most important thing is to think about what factors should the health information system be addressing. And these are some of the factors, not all of them, but really important to think about them. Then we need to have sociodemographics, know who is the individuals, health costs, hey, what is the best alternative, and how we can optimize the services and reduce costs. What is the health infrastructure that is available, and what is the closest place where I can go to obtain services? What is the health status of the individuals, the communities, and the society? What are the risk factors that we are exposed? And we can do that in real time. I don't know if you remember when COVID, there were in attempts to have exposition alerts using cell phones or things like that. How disability is going to impact in the way that we access health services or we access information. How to really understand, monitor, and predict or survey disease outbreaks, and how we are going to use that information to improve morbidity, mortality, and being able to register that in that way. And as I mentioned, this explosion of data is allowing that the medical knowledge, just the medical, not the health in general, is doubling every 73 days. In the 50s, it took years to double the data, and this is an exponential growth that we see. Then basically, we are not able to absorb the knowledge or that aggregation of data that is being produced collectively in nowadays. Then, if we think in the functions that a health information system should have, then the ultimate goal is to facilitate timely and evidence-based decision making while increasing efficiency of the hospital network or the healthcare services in general. We want to monitor the assets and inventories that we have and the resources. We want to track the status of the patients, and at the end, we want to improve the healthcare outcomes. But that said, it's really important to think that we have challenges. There are huge challenges, especially in the data flow, in the interoperability, and that's the reading that we're going to be doing in this session, how these elements are necessary to overcome and the different challenges that we're facing in order to really be able to move data from one source to the next step and be able to use them efficiently. Now, we want to introduce that concept of databases, and here is where we want to see that importance, and we want to understand the databases in the context of healthcare. Then, why is important to have a database? Then a database that is that structure that stores the data are the way that we are going to store the data. Remember that we captured the data, but we need to save that in some way. And one of the ways the best way of doing that is through a database. Databases are not necessarily electronic. We can have paper-based databases. If you think about the yellow pages in the past, that's a database of business, phone numbers, addresses, and you can query that database. But when we have structured data and we are able to manage that, then we can organize, retrieve, and then we can retrieve all these things that we want: the demographics, the clinical documentation, the operational workflows, anything that we want to really know, the laboratory results, the pharmacy orders, these things. If we organize them in such a way, then we are going to have a structure and manage them. Then we can enhance the clinical decision making, because if we can query that database, we are going to have access to resources to the providers to improve the outcomes. Or for example, if you are unconscious and you come to an ER, and we can query what are your past medical history, maybe we're going to have better insights what to do or what not to do in the moment that you are coming here. And that database is going to be represented through that health information system that is going to be the electronic health record. Basically, when we think in health information systems, they are going to be a database in some way in the back. The electronic health record, the lab information system, the pathological information system, the hospital information system, all them have databases on the behind. Then the other thing that we need to know is that if we design properly the databases, we can interpret across departments or across institutions and be able to do reference and quarter references. Then that's why we have standards in the way that we collect the data, standards in the way that we communicate the data. That's really one of the advantages to be able to coordinate patient care. The interesting thing is when you implement systems, sometimes you develop the database, you have a standard, but we have a traditional informatics problem that is called the Cooley braces problem. What is that? That not everybody standardizes the name of the variable in the same way. Then that's a task to do and a challenging thing. And that's the level of what we call the semantic interoperability, because sometimes people just say, hey, this is the blood pressure, or some people say this is the blood tension. And those for a computer are two different things, but for human beings, those are the same things. Then overcoming that is one of the important things, at least in the representation in the database level. And databases help us to support the quality improvements. Then they aggregate data from databases and different sources, and we can create all those predictive models, and at the ultimate goal of improving patient outcomes, as I was showing you in the evolution of health information system. Then basically it's almost impossible to think a health information system without a database, and that's really what we want to reflect about that. But if we think about what is a database management system and how we can apply them in healthcare, then there are different types. But the roles and functionality of database management system, that is the piece of software that is helping us manage the data. Then the first is going to provide some structure and the way that we access that data. And we are going to see in the different types of databases that, for example, there are particular languages that we can have to have a common way of retrieving the data. And that's something in the DBAs, the database administrators, are training on how to optimize those queries. And SQL stands for the select query language. That basically the select is one of the main functions of the language. That is, hey, I want to select this piece of data from the whole data set, and how I create that set. The access control and privacy, that's one of those layers that the database management system is going to provide. Then we don't want everybody to be accessing everything, and that's really important to segment what we can do, or who can write, or who can update, or who can delete. In healthcare, the recommendation is never delete. We do logical deletions, and basically we void data, but the data is preserved in the database. Because once you delete something from a data set, it's gone. Then it's better to keep the history, and there are different strategies to really maintain that history. And we want to really maintain privacy and be compliant with the regulations. And another strategy is that they identifying elements in the database, usually they are going to be encrypted, and there is a mechanism to encrypt and decrypt that, and that mechanism is provided by the database management system. Now the data integrity and accuracy is, we can create some rules to keep data structures appropriate when we are doing modifications. For example, you come to an ER, you were unconscious as the case before, but we cannot identify you, and then you are going to have a new record in the electronic health record that is going to be John Doe or Jane Doe. And once you wake up or a family comes looking for you, we can identify you, and now we are able to pull your old record. And the thing is, when we unify them, we really know that the decisions that we're taking while you were unconscious is what they were made under the name of John or Jane Doe, because maybe I didn't know your past medical history, I didn't have some information, and I may have done actions that were not really completely indicated or were risky for the patient, but the decision making was made on the best knowledge that was available for the provider in that moment. Then that data integrity and that past and those relationships are really important. Or sometimes when we have identity thefts that in healthcare occurs, somebody is presenting as somebody else just to gain benefits because you don't have insurance and your brother does, and then you are pretending to be your brother, or a female pretending to be the sister. But that has implications once you discover that, because the diagnosis that was done, it doesn't belong to that patient, and then we need to be able to solve that type of of problems. The other thing is concurrential data backup. We need to manage multiple users querying the same data set, and we want to be able to have backups and recover from disasters because we don't want to lose the continuity of care. Then these are really interesting properties that the database management systems are going to provide in order to make a safe environment. Now, I had mentioned that there are different types of database management systems that we can use in healthcare. Then the most common one is the ones that we call the relational databases. Those are the traditional databases. Basically, you have tables, and the tables have relations between them. That's why it's a relationship, no? Then I have a table of patients, I have a table of services, I have a table of medications, I have a table of procedures, and then I have a table of encounters where I can mix the patient, the provider, the service, which medication received, which procedure received, and instantiate that. And examples of structured relational databases are the electronic health record, the laboratory information system, part of the radiological or the reporting information system, and part of the pharmacy systems. Why I say part? Because the standard de facto for the radiology is called DICOM. And DICOM, it's a non-relational database. It's part of those non-SQLs, okay? And what it does, it creates a hierarchy of files in folders, and that way is how we access the data. Then in the first folder, we have some identifiers that is going to tell us what is inside, and then in the inside, we are going to have the other elements. Is how is mentioned, there is an object oriented because the object is going to be the study that is going to be associated with the patient. But we can have distributed systems where, for example, I have the image stored in that way in the DICOM file that is going to be this hierarchical object, but I can have an index telling, hey, for Jose, for this patient, I have the files stored there, and there, and then I can use multiple ways of managing that data. Or when we have health exchanges, some of the health exchanges, they know, hey, this patient is going to these different hospitals, and when I want to have a full view of the patient, I can query those different systems and bring them together. Now, if we move into the topic of networking and how we integrate that information flow in the domain, then it's going to help us to think that creating networks, connecting systems, connecting computer is really important, because I have experience, for example, when I have a patient come to the ER, but that system was not connected with the inpatient system. It took 2 hours to somebody just do the transition of the things. You are in the same system. You are in the same hospital, 2 different departments, and the systems are not connected, even though the computers are connected to the same physical network. That's something that happens, and that's something that we really need to take into account. And be able to exchange the data and be able to move the data is fundamental to have really a successful health information systems. Then also, if we have networking and we can facilitate that connectivity, is when we have telehealth. We can connect remote access, or we can use cell phones or any other type of communications and bring the data when it's needed. Here is really important, those standards that we're going to be discussing, and one of the families of standards that is more common in healthcare is called HL7. Health Level 7 stands for the different layers of a system. The level 7 is the application level, and the level 8 is the user. Then HL7 is how we specify in that high level the exchange of data, because we are not concerned about the level 1, that is basically how you design the cables, what is the electricity, what is the frequency of the clocks, or what is going to be the negotiation of the communication between the computers, as where we have the World Wide Web or the HTTP or the TCP and all these concepts of communications. And there are different layers going all the way to the communication level that is Shell 7, and Fire, that is one of the newest versions of that family of HL7 standards that is really powerful, and we are going to learn a little bit about that. And of course, if we want to do clinical decision support, we need to bring data from different places and be able to produce the alerts where they need to be actionable. Then, for example, in the past, we have a project where we wanted to monitor dialysis, peritoneal dialysis machines, and just monitoring those dialysis machines, then the nurse could call the family and do adjustments, and that impacted in the outcomes of the patients because they were not suffering of a frequent complication, that is the peritonitis, and the outcome at the end was improved just by that interoperability of the system, having that telehealth and being able to have an alert system that allow us to create actions. Then how these things work together, for example, then when we have orders, then the database management system, for example, is going to store, is going to validate the order, but the networking is going to transmit that order to the department, and then we need interoperability. I want to have a lab, then I can store that order in a database, but I need to communicate the lab, hey, this request is here, and once the lab receives the sample, they need to be able to match the sample with that request, and once the result is completed, then how I return that data to the original patient and be able to store that result. Or in the clinical documentation, is the database is going to have all the nodes and all the different elements or measures, and the networking is going to help us to access that from different ways. In decision support, the database is going to provide the data that we need for the analysis, and the networking is the one that is going to be distributing the alerts in real time. Where I'm going to be sending that is going to be as a text message, is going to be a phone call, is going to be an email. What is the type of action and how we're going to distribute or communicate that finding. In patient tracking, for example, then we can maintain location and status of the data or the status of the patient, and then of course that networking is the one that is going to help us to track the patient. Then some examples and summary. Then patient tracking system healthcare is a real-time patient data management. Basically, we may have a database management system that is going to be local in the device of that patient, or in the room or where the care is being delivered. The network information and distribution is that network that is going to help us to update different individuals about that data. Then let's say that I arrive to the ER, then notifying, hey, this patient here need to be trashed, and once I'm trashed, I need to move the patient to a different place. Or if I am home and my glucose is high, then who I'm going to be notified in order to provide an action. Or maybe I have a closed loop there and I have an insulin pump, and the system is going to manage that pump, deliver additional insulin, but report that, hey, we adjust the dose of this patient and we need to be careful. We can improve workflow and coordination. Then as I mentioned, when we're tracking these patients with peritoneal dialysis and tracking the machines, we can enhance the workflow and we can coordinate better outcomes. Or we can also look into where people are being stuck and not moving through a hospital or through the healthcare system. And we can also use this type of things to operational analysis and resource allocation, because once we identify where it's needed, we can optimize the resources allocation. In summary, Then health information systems is a data management tool that originates in multi levels from the patient to all the way to global registries. We have big challenges in the data flows and standardization. And some ways of doing that is through database management systems, standardizing them, and through networking and standardizing the communication. Then we discuss a little bit about the role of the database management system in healthcare and how they can help us to organize and protect that data, and how this is this first layer of storage. But we also introduce the networking capabilities to enhance communications and how we can support that function of transporting and transforming data. We also introduce a little bit of types of database management system, as the traditional ones, the relational database, and that are non-SQL or non-relational based, and they can be object oriented or they can be distributed, and all of them can live together depending on the functionality, because they have advantages or disadvantages that we can explore and lever on them. And at the end, improvement of care quality and the healthcare outcomes is the result that we can have, or we hope, when we are implementing health information systems. Should be the ultimate goal, even though some of the implementation has been motivated for different motives. Thank you very much, and until the next encounter, have a good one.